Were you here for the first two talks?
Yeah, I missed.
So the first two was more like non-invasive, and then the basics, and then basically as it goes on, it gets more difficult, more advanced. Like as the last talk was PIT, we started getting more advanced. Now, these are bedside measurements for monitoring effort and drive to breathe from the patient. So again, slightly more advanced, but not necessarily difficult. This requires an actual device, so it's not that it's difficult. Just if you don't have it, it's not helpful. These are proportional modes of ventilation, which in some hospitals they use. I'm not sure how familiar everyone is with it, so whether or not we talk about it.
There's more these advanced monitoring and advanced modalities.
Yeah.
Which
This
winning
is
a liberation is like a very common topic.
And I would argue that this here, I think, is an essential for anyone who looks at a ventilator, because asynchrony often goes unrecognized, and some asynchronies are associated with poor outcomes. Whether may not be causal, but if we can recognize and fix half of them, then there's no reason why we shouldn't. So we're definitely going to do that. We'll do that now, and then maybe we'll do meeting of enumeration. Will that be? Looks like you're up, because then and then whatever time we have, we can discuss anything. We can review, pressure time curves on the ventilator, even when you don't have a flow volume loop. Like there's a number of things we can play.
Because I think instead of doing maybe the recruitment to inflation ratio, would be nicer to do the maneuver there.
Even AOP, even just assessing for AOP, which I think would be beneficial, even if you don't calculate recruitment to inflation.
Just to show how easy it is to do it on a ventilator without.
Yeah, okay. So we'll get started with, I just wanted to put that up there so that we could have the question asked. Yeah, so I was just asked if I would share the slides, so the answer is yes, so I'm going to provide slides to you. Yeah, and I think, did everyone scan the QR code when you came in?
Yes.
Okay, yes. Okay, so if you did, then they'll I think that's why she asked me for the slides, that they're probably going to be available to you. So we just haven't had a chance yet. When we were on lunch, I saw a message come through on WhatsApp, so I just haven't.
Plus they did a video, I think they're all recorded.
Oh, yes, they're recording.
Just start.
Yeah, I think to start.
Good afternoon. I'm going to talk about the respiratory effort and drive and its relationship to the emerging concept of patient self-inflicted lung injury. This concept has been forgotten a long time ago, mostly in most ICUs, but it had re-emergence again during COVID time. How many of you took care of a patient with a COVID time and the patient was ready to be weaned, extubated, sedation was stopped, just to realize that the next day he's again 100% viable, or there is actually worse than you did, yeah? So because of this phenomena with the COVID patients, respiratory and effort and drive has been actually taking more attention again compared to prior to COVID time. So I'm going to talk about the difference between respiratory drive and effort, how do we monitor it, and some strategies to minimize the drive and effort. So we'll start first about talking about the respiratory drive and respiratory effort. If you see there, the respiratory drive, by definition, it's actually the neuronal impulse or input to actually start the stimulation of the respiratory muscles. It can be normal, it can be actually very strong, which causes vigorous contraction of the diaphragm and the respiratory muscles. On the other hand, the respiratory effort is actually the response of that drive, the muscular response. They can be actually somehow the same or related, but in patients who has muscular atrophy or has weak diaphragm, he might have a strong respiratory drive, but this is not actually translated into an effort. So why this is actually important with an extreme effort of the respiratory muscles, what you're going to have is an increase in the transpleural pressure. The Bendelov will occur where actually the air will be taken from certain areas of the lung to other areas of the lung. There is an increased venous return leading to increased pulmonary edema and increase in RV afterload. This will result into further lung injury, and the further lung injury will result into trauma, barotrauma, atelectatic trauma, etc. The patient enters a vicious cycle of patient self-inflicted lung injury. And if you look closely at the respiratory drive itself, not the effort, the respiratory drive is controlled mainly in the pons and in the medulla. And there are many inputs where actually tell the pons and the medulla that go ahead and increase the respiratory drive. And this includes on the top there, emotions, behaviors, like agitation, delirium, etc. Yeah? But on the other hand, there are other factors that determine this, like the pH, CO2, the PaO2, and also inflammation in the lung, and low support from the ventilator or low pressure support from the ventilator. Basically, what this slide tells you, it's not easy to suppress the respiratory drive. It's not simple to choose only one parameter, like for example sedation or narcotics, because it will affect mainly the emotion and the behavior, and it will not work on the other parameters. So why it's very important actually to monitor it, or to monitor the respiratory drive and the respiratory effort. This is just like one of the examples. This is like a COVID patient with an L-type kind of COVID. And this is the respiratory effort that the patient actually have with a pleural pressure of, I think, near 11 centimeters of water. Throughout the days when the patient was actually followed from 0 to like 15 days, etc., there was no worsening in the patient hypoxia or the features of ARDS. On the other hand, there's an L-type with a patient who has high distress with really negative swings in the pleural pressures, and this resulted into the H-type and maybe later the F-type. So it's very important actually to monitor the drive and the effort in order to somehow prevent this progression. And if you look at this slide here, this vigorous respiratory effort can result into different kind of mechanisms that leads to the worsening of respiratory failure. So you have features of global overdistension, maldistribution of the lung stress, increased lung perfusion, asynchrony, derecruitment. And this is one of the examples of the Bendeloff phenomena, because if you see the diaphragm, the diaphragmatic muscle is mostly strong in the dorsal side here. With an increased drive and increased effort, this is where the most vigorous contraction actually happens, which leads to air being entrained mainly in the dorsal side and sometimes on the ventral side. So in this area, we'll have overdistension, you will have increased transpleural pressure, and this is the area which is injured from before, and this is the area which is more vulnerable. And this is shown here in this PET scan, where you see in the PET scan area of increased inflammation with the increase of the respiratory effort or drive. And this is another example. This is an animal model. Like on the first two there is in A and B, it's like a healthy animal. And here, this is where they induced actually ARDS. And here, where there is increase in inspiratory effort by induction of the ARDS and the inflammation. And you can see very clearly how actually the pulmonary edema as well as the signs of inflammation occurs even at the histological level. Because of all of this, it's extremely important actually to monitor the drive and to monitor the effort. And there are many ways this can be done. So it can be done in a spontaneously breathing, non-intubated patients by looking at scales, like the Ward breathing scale, Stroke scale, and the Hooker score that you use in high-flow nasal cannula and in NIV. On the other hand, here in mechanically ventilated patients, several parameters actually can be used, which are the occlusion pressure or intra-expiratory airway occlusion maneuver, or occlusion pressure at 100 milliseconds. Both of those, you will hear actually the name being used interchangeably, but they are actually different. They are not the same. And I'll explain them in a minute. On the other hand, one of the standards that are actually used is esophageal manometry, which will tell you actually the change in the pleural pressure and the muscular pressure as well, and the diaphragmatic electrical activity. And because both of those, we don't have them readily in all the patients, but we have a ventilator on a ventilated patients, it makes sense that makes sense to find surrogates for inspiratory drive and effort, and the one that we are going to discuss is the occlusion pressure and the pressure at 100 milliseconds. So we'll start with the respiratory drive and the occlusion pressure at 100 milliseconds. So what is it? The occlusion pressure at 100 milliseconds, basically in the first 100 milliseconds of taking the breath, the machine actually, some of the machines do occlusion and measure what the pressure is. Some of the machines like Hamilton, what they do is they don't do the occlusion. The machine automatically does not do the occlusion. It just like infers what will be the occlusion pressure by looking at the curve. But Servo I, Servo U, etc., all of them, they actually do that part of the occlusion. Now, the occlusion pressure at 100 milliseconds, that 100 milliseconds, it tells you more of the respiratory drive rather than the respiratory effort. So it's not affected if the patient diaphragm is weak or there is a neuromuscular weakness, etc. It tells you more of the neuronal input from the brain. In Hamilton ventilator, it's like calculated automatically. You see it here, it's like the occlusion pressure here is minus 3.9. And if you want to know if this occlusion pressure at 100 milliseconds is really representative of the respiratory drive and the neuronal input, there is this study that actually looked at the correlation between the occlusion pressure and the electrical activity of the diaphragm in healthy subjects. And actually, it is well correlated, and you can use it. And this is also another study which shows you the occlusion maneuver as well as the esophageal pressure at 100 milliseconds, and there is a good correlation between them. From those studies, we have actually somehow a reference range. What is a safe occlusion pressure? It's between 1.5 and 3.5, or minus 1.5 and minus 3.5. If it's more than 1.5, so it's like 1 or 0.5, it tells you maybe the patient is actually over-sedated and he does not have enough neuronal input. On the other hand, if it's more than or less than minus 3.5, it tells you that the neuronal input is actually extremely high. The patient is at risk of developing patient self-inflicted lung injury. We use the occlusion pressure routinely in the ICU, like as a monitoring every 4 hours, etc. So before COVID, I didn't use it, but after I saw what happened in COVID, we made it actually a routine in our ICU to measure it every 4 hours, especially at the time where we go ahead and stop the sedation or stop the paralysis. So is occlusion pressure or measuring it actually matters or not? Well, there is no RCT actually to look at it. I think there's an RCT now that under recruitment, but some observational studies actually looked at the correlation between the occlusion pressure and weaning failure or weaning prediction. So if you look at this side here, this is the occlusion pressure, sorry, on that side there, that's the occlusion pressure and weaning success and failure. And as you see, an occlusion pressure which is actually lower or within that target, less than 3.5 or less than 3.4 or less than 4, it's associated with higher chance of success of weaning compared to a higher occlusion pressure. This was compared to also the occlusion pressure if your diaphragm thickness is intact, if there are no features of atrophy. And if the diaphragmatic thickness is intact, actually the correlation is much better, and it tells you that the occlusion pressure, which is less than 4, it's highly associated that the patient most likely going to be weaned from mechanical ventilation. So this is the occlusion pressure at 100 milliseconds. So this is more of a determinant of a reflection of the neuronal input or the respiratory drive. Now, when we go to the respiratory effort, there is another measurement for actually the respiratory effort, and the measurement that we use here is the occlusion pressure, or PO. So PO is actually a maneuver that you perform. The machine does not do it automatically for you. So basically what you do in the PO, you do an end expiratory hold. All right, in the study that they used 5 seconds. And then what you do is you see what the pressure is. That drop in the pressure, adding to it what PEEP the patient actually had, it tells you the total pressure that the patient actually use to suck in or use actually in order to drop. And this is a reflection of the respiratory effort, not the respiratory drive, because you can see here the TMUS actually is correlated with the drop in the PO. And because you want to calculate the PMUS and you want to calculate the change in the pleural pressure, and not everyone has an esophageal balloon there. A study that was actually done that looked at the correlation between the POC and the other measurements and gave an algorithm about how to use it in clinical settings. In this study, they recommend that every 4 hours, basically you do the POC by actually the maneuver itself. When you get that measurement, then basically you will be able to calculate from that side there what is the TMUS and what is the change in the pleural pressure. And you can set, like according to the center you're in, what would be an acceptable limit actually for you. But in this study, this is the acceptable limit, which is for PMUS 13 to 15, and for the predicted change in the pleural pressure of 16 to 17. And then after that, you can do whatever strategies in order to reduce the PO. Now, again, when you look at the PO, you want to answer, you want to see if the PO actually is associated with poor or good outcome. But again, there are no clear studies in this term, but there's this study that looks at the risk of relapse in COVID patients. So if you have a COVID patient, the respiratory failure is actually improving, you do the PO, and the PO is abnormal, is it associated with increased relapse of respiratory failure? And in this study, actually, they find a good sensitivity and specificity of the relapse of the respiratory failure if the patient PO is actually beyond the safe target or safe rate. Now, if you're also interested in using ultrasound, you can actually determine the respiratory effort by using an ultrasound. So the way to do this is to use a linear probe, and the linear probe right here, you'll be able to get the diaphragm and to check what the diaphragm thickness is. And then after you check the diaphragm thickness on inspiration, it will cause, like when the patient breathes, the diaphragm will actually become thicker, yeah? Then you can calculate the thickness fraction. So the thickness fraction, 30% or more, tells you actually the effort is very vigorous, and maybe you need to do something to reduce the effort in a patient with extremely high effort. So this is occlusion pressure and how it's correlated to the respiratory drive. Respiratory effort. So if you have now a patient with high respiratory drive and high respiratory effort, what would be the strategies that you can use to reduce it? And from the beginning, I would say it's not as simple as increasing the patient's sedation or narcotics. So one strategy you can actually use is increasing the support. And this study actually showed that where you increase the patient support or pressure support, it makes sense, yeah? If you increase the patient support, you'll see actually the occlusion pressure and not the occlusion pressure, you will see the occlusion pressure at 100 milliseconds or the respiratory drive decreases because of the recruitability of the lung, more support, etc. But there are other ways or other factors that will help you to reduce the respiratory drive and the respiratory effort. So if you look at this slide, it's a bit complicated slide, but here you will see that there are so many factors that affect the patient respiratory drive. It includes from higher cortical center, pain, anxiety, discomfort, etc. The arterial blood gas, things related to the lung mechanics as well, and de-recruitment, and inflammation. And it affects several axes that controls the neuronal input of the respiratory drive. So because of that, when you come to treat a patient with a high respiratory drive or high respiratory effort, you have to think beyond just like using sedation or beyond just like using paralysis. In this situation, there are many things you can do in each axis. So you can use sedatives, they added the music there, but I don't think it will be very useful. But sedatives, for normalizing the ABG, I was talking to the organizer earlier that even increasing the FiO2 of the patient from 40 to 60% without changing anything on the ventilator can actually has an effect in decreasing the respiratory drive, especially in COVID patients with increased inflammation and sensitivity of the peripheral chemoreceptors. So they will not tolerate the 60 to 80 PaO2, they might tolerate actually the 80 to 110, and it will reduce that as well. Prone position also can help correcting metabolic acidosis using anti-inflammatory therapy. The paralysis, you can actually still use paralysis, and there is a study that looked at using partial paralysis where you use half of the dose of the actual infusion, not the full infusion to cause complete paralysis, but infusion enough to suppress the respiratory drive and suppress the respiratory habit. Okay. That was basically like my thought. Thanks.
When you do the POC, because this is a method that we always discuss, which of the drop you measure? The first one, the second, the third, because each one can be different.
I think average between the three of them.
Yeah.
Yeah.
Not the first one, because depending on how the
Do you mean three in the same hole? Or
the same hole.
So I think the first.
Yeah, so we use the first one, but it can be very different. Patients that are tired with some atrophy, the second, the first one, the following one will be lower than the patient with strong respiratory muscle. The PO can get much deeper as you.
The longer you hold it becomes more of a
If the patient can make it, if the patient is weak because
it gets weaker
is a
over
problem.
time. Yeah, so you can have either.
So that's why it's, and that can lead to very different interpretations, so.
It's usually a single breath occlusion, one breath, but you're right, you do three of them, separated apart, give the patient some time to recover. How far? It's really up to you, I think, at these 5 breaths.
You can do them within the same setting.
Yeah, you don't have to change, you don't have to go up and come back, just wait. But the other thing that's important too is not to instruct them.
Yeah.
If you tell the patient what you're doing, it's not like a NIF where you want them, like, I'm gonna do this and you're gonna take a deep breath. You don't tell them. You just say, I'm just gonna do some measurements here, that's all you can say, but then you don't prompt them. You do the maneuver and say, and then as soon as it stops, they might look at you, but they're breathing fine now, and then again, so you do 3, you're supposed to take the average of the 3, but you don't hold it and take 3 breaths in a row, because as Lorenzo pointed out, in some patients, it will get stronger. In patients that are very weak, it may get weaker, so it kind of confuses the value. The key is to catch them off guard and to get the first breath you get, because it will reflect what was going on prior to that. Anything beyond that, they start to recognize that you're occluding the airway. And you'll likely see a change in EDI, but the nice thing, if you look at that graphic, even though the drop in esophageal pressure is larger, that has to do with isometric stuff. It's not an increased contraction, the EDI is stable through that single breath. Any more questions? That was very, very good, very quick. We might get back on track now. Excellent. Until I. Okay, my disclosures have not changed. We're going to describe the most common forms of asynchrony, discuss some of the clinical consequences, and then describe methods to correct and manage these asynchronies. I'm also giving another talk during the conference on asynchrony, so you will see some similarities. I won't be doing the voting in the actual conference, that's going to be for us. So, and your names don't show up, I won't know who voted what, so don't feel embarrassed. I want you to just participate and try to learn. First of all, the key to understanding how to recognize asynchrony is to make sure that you understand how to detect patient effort. Many ventilators will tell you the patient triggered the breath. It'll either have lungs that pop up on the screen, or you'll see a different color in the waveform, and we'll see examples. It's very clear that the patient's triggering. And that's really the first step to identifying asynchrony, is
did they trigger the breath? Because one form of asynchrony, the patient would not trigger the breath, but then they would respond afterwards. It's called reverse triggering. So first thing is, did they trigger that breath? If they did, it's not reverse, whatever you see after that is not reverse triggering because the patient triggered the ventilator, okay? Identifying PMUS, again, has to do with understanding the equation of motion. Remember, if it's volume control, what's gonna change? Pressure. If it's pressure control, what's gonna change? Flow and volume. So where you look depends on the mode, and that's how you identify asynchronies. Now the trigger is the same for all ventilators. You can see a little drop, but afterwards, if effort is prolonged or if it's occurring after the ventilator cycles off, you need to look for this evidence. And keeping in mind that when the ventilator cycles off, every mode acts the same. It's passive exhalation. So any activity in the expiratory phase, it doesn't matter what they were on before, you should see similar patterns during exhalation because it's just the ventilator cycles off. And if the patient's breathing and not triggering the ventilator, you should see these patterns and they all look the same. So I don't need to review this again, we know. In volume control, we're looking at changes in pressure. In pressure control, we're looking at changes in flow and volume. And then PMUS will shift, work, and alter the variable that is not controlled. Okay? We've already seen this, we've seen this, we've seen this. Okay, categorizing. Some people will categorize asynchronies as either a triggering problem, a cycling problem, and then flow starvation. Okay, so a patient could trigger it normally, they could cycle normally, but if you don't give the right flow and volume control, they may be flow starvation. So that's why I've separated this out from this group. Now I'm going to show you my preferred method of classifying is not this, but just so you know, we have triggering. We have auto trigger, delayed trigger, ineffective trigger, double triggering, which leads to breath stacking. Reverse triggering can also result in breath stacking. But when I talk about reverse triggering, I want you to understand, because some people misinterpret this. They think that reverse triggering, you have to have 2 breaths. Breath stacking is a consequence of reverse triggering, but it's not required. I'll teach you how to identify reverse triggering. And again, how I'm going to teach you is without fancy tools, which means someone could disagree with you and say, well, again, the way that we confirm asynchrony is esophageal pressure, which we mentioned, or EDI, like electrical activity of the diaphragm. That's how you can be certain what you see is asynchrony. Having said that, to the trained eye who has seen all of the tracings before, I'm going to teach you how to look at the pressure and the flow and assume that what you see is asynchrony, and you'll see the patterns and you'll see how it can be. The assumptions I don't think are that crazy. And software has been trained now to identify it without esophageal pressure and EDI as well. Now, so let's just talk about triggering and cycling first, and then I'll get into how I like to classify them. So triggering, this red line represents PMUS. So you see the breath is triggered there. This is late trigger. It just means the patient's making an effort, but there's a wider gap between when they finally trigger the ventilator. And then there's, in this paper they call it early trigger. I'm not a fan of that. Reverse triggering is what we've been referring to it since 2013, so I'm going to keep going with reverse triggering. But notice the patient did not trigger. See how this ventilator, it turns yellow, or white. I don't know why it didn't turn white there. But this is flow trigger, it turned white here. This is pressure trigger, it turned white here. This one, the patient did not trigger. But look what happens during inspiration. There's this effort. It's almost like a response, like a stimulus. The ventilator comes first, then the patient, and this is why it's called reverse triggering. Okay? But there's not a breath stacking breath, right? This is a pressure control mode, I can tell, because pressure is straight. They make the effort here, and they get more flow, and then the pressure goes up because there's a pause here. This is the elastic recoil of the lungs. See how the patient's relaxing here? It's demonstrated here, and then it finally cycles off. So this is reverse triggering, but also delayed cycling, which I'll talk about. This means the ventilator is taking too long to cycle off. This is false trigger or auto trigger. It means something is causing the ventilator to trigger. It could be a leak. It could be cardiac oscillations. Cardiac oscillations wouldn't do this. Cardiac oscillations look more like normal breathing. That's why it usually goes unrecognized. So there's reports of brain dead patients that they were doing apnea testing and the patient's breathing on pressure support, but there's no brain activity. And it was the heart was triggering the ventilator, so it gives the breath. Exhalation occurs as soon as flow reaches 0. You see another breath simply because of cardiac. When it's doing this, it's a leak. And your ventilator is likely alarming right now. There's no expiratory flow. It's going to alarm you. And then this is fail trigger, what I refer to as ineffective effort. And I'm going to tell you why I call it ineffective effort is because although the patient's making an effort here and they're not triggering the ventilator, I find over the years calling it ineffective trigger makes people think they have to adjust the trigger sensitivity on the ventilator. And that is the last thing you need to adjust in the ventilator, unless someone has said it inappropriately. But if they trigger this breath, no problem, and then they miss this one, the problem is not the trigger sensitivity. I'll tell you what the cause is, but it's not the trigger sensitivity. Everyone understand? Over the years, I've gone by many ventilators where the trigger sensitivity is set to like 0.1, and you can still see all these ineffective efforts, and I'm like, I clearly understood why they did it. They thought they could get the patient to trigger, but that's not the problem. So cycling is all about time, right? We don't know the neurological time of the patient unless you have something like esophageal pressure. You don't even need to calculate PMUS, but you would see the swing in esophageal pressure. If we see it, then we know if cycling is on time or not. So when we call, even though they call this normal, I kind of joke because they trigger and technically they're done breathing here, but that's definitely not cycling off normally. But this is a patient who's probably not ready for spontaneous breathing. They have a very weak effort. They're going to start, but that's a normal trigger, and then cycling based on what you would expect. In this here, you see the patient's taking a larger breath here, and this is where they start to exhale here. And notice how there's a pause. This means I've set a fixed inspiratory time. There's a pause in flow, and when that pause happens, you actually see this little blip up here, this plateau pressure. And so that's delayed or late cycle. And then early cycling, you'll notice the ventilator cycles off here, where this red line is, it cycles off. And how do I know it's early? Well, the expiratory flow will be blunted. Notice how there's a spike. When you see it rounded or blunted, it basically indicates that effort is continuing on past the point at which the ventilator cycled off. So the brain wants to breathe this long, the ventilator cuts off here and says, I'm done, because I've told the ventilator to cycle off. Again, these are settings that we control. We control the timing. Even in pressure support, people say there's no I time. They go, oh, the patient does what they want. No, the ventilator cycles off at a set time, not time, but at a set point. And usually it's something like 25% of peak flow. But that's a setting we can adjust. I would argue most RTs don't know that they should adjust that in some patients. And some patients it's more important to adjust it than others. So the blunting there, you can all see how PMUS impacts it, right? When the breath goes on beyond, you see this, and we're gonna have a couple of different examples with that. Now, work shifting is a word that's used in this paper, but essentially what I call this is just the level of assistance. So work shifting means work is being shifted to the patient. And how do you know that? Well, in volume assist control, where you're fixing the flow, if the patient is not breathing, there's going to be no impact on the pressure. If the patient is breathing during volume control, now this is actually reverse triggering. Notice they did not trigger. That's their effort here. There's a drop in pressure. And this, because flow is not changing, if it's not fast enough to meet the demand of the patient, you see a drop in pressure. If I was giving much higher flow, you may not see their effort in the pressure waveform. If the flow exceeds the demand, you won't see it. But if it doesn't, you're going to very clearly see it. And in this example, this is what I would call severe work shifting or under assistance. You could argue that this is not necessarily under assisting. This is under assistance. Again, it's reverse triggering, which I don't know why they did that for this paper, and they should have had them triggering here, but notice that the pressure drops below PEEP. This is PEEP, and it drops below PEEP. This is flow starvation, okay? If you ever see this using volume control, please change your ventilator immediately to a pressure-targeted mode of ventilation. You need to remember everything I'm saying, because when the questions come up and you have to answer, remember, if you see this, you're going to switch to a pressure-targeted mode of ventilation is the first thing you're going to do. Okay, in pressure control, it's a little different to recognize because you'll just see differences in shape, but this is normal pressure. It goes up, goes down, okay? So there's no evidence that the patient is demanding work. Again, when there's a little bit of effort, you get a bit of rounding. That's okay. Even rounding like this, although this is increased work, the dotted line is the pressure that the ventilator is supposed to reach. Notice how there's a plateau here. It's because there's a pause.
and this is the elastic recoil. So again, if I didn't see that, I see this is happening and I see this pause, this is like doing a plateau pressure, right? And all it's reflecting is the elastic recoil of the lung. So this is actually your true driving pressure in this patient. Now over here, we have a very significant effort. You see that the ventilator it cycles off right at the end, but there's already this huge spike because right here, before the ventilator cycles off, this huge effort is now, the passive recoil has begun, the lung is now, the patient's going like this, and this is reflected in the pressure. Okay, so anytime you see these spikes, it could be that the ventilator is not reaching it at all. Like if you stopped right here, it just means that it didn't reach it yet. But when you see these very abrupt spikes and almost zero flow, here it's very obvious, here it's not so obvious, but that's what that is. Okay? Now, if a patient is forcing exhalation, so when they're forcing it out, your expiratory flow, rather than going nice and exponential, you should see an exponential curve during exhalation. If the patient is forcing it, it may start and then it sort of rounds out like this. And then sometimes some patients will breathe out and then they'll force out. You'll see it come back down like this and then they trigger. Sometimes it's hard to determine whether or not it's an ineffective effort, they breathe and nothing happens, or if it's a force. For that, you have to look at the patient. You'll see them forcing out. But generally, it pushes the flow down this way when they force out exhalation. Ideally, you want just passive exhalation. And I already explained how resistance and compliance, again, resistance flattens that out. Now this is like how I like to classify async, okay? And this, every question I ask you when you have to poll, is you're gonna be first asked, is this over assistance or under assistance? Okay. Now how do you determine that? Well, for one thing, if you can identify the asynchrony right away, then you can classify it as over assistance or under assistance. But the reason why I like to classify it like this is because this describes the problem that's underlying, that's causing it. So if I have a trigger, if I have ineffective efforts, okay, I have ineffective efforts. What's causing it? Most likely over assistance. Okay, so ineffective trigger or ineffective effort is here. Delayed cycling, I bolded these because this is the #1 cause of this. It's not a trigger sensitivity, it's delayed cycling. I'll show you a nice picture that's coming up soon. Auto trigger, you're over assisting because you're giving breaths that the patient doesn't want. It's auto triggering, right? Reverse triggering is a difficult one for calling it over assistance because maybe the volume's okay and the rate is okay, but in some patients, if you just lowered the respiratory rate, the patient would now trigger every breath and they don't have reverse triggering. Like it's a phenomenon, the patient's trying to entrain with the ventilator, and if you just lower the rate, the patient can take over. In some patients, when you do that, they actually have no drive without the stimulus. Without the ventilator pushing and they respond, some patients you put them on pressure support and it's apnea. Okay, so in those patients, I wouldn't say it's over assistance, you're probably over sedated because this happens commonly in sedated patients, this reverse triggering phenomenon. And then under assistance, flow starvation, I think we'll be able to identify that in volume control very easily. Pressure control is a little bit trickier. Delayed trigger, I won't quiz you on that one, just so you know. Early cycling, again, the ventilator cycles off. Under assistance, based on time, it's cycling off too early, it's not supporting them the amount of time that they want, so it's under assistance from a timing standpoint. They might be getting enough support, but not long enough, okay? And then double trigger, of course, and breath stacking. The patient is taking one breath, the machine cycles off, so they have early cycling, and then it triggers a second breath. So these two things, this causes this, but you can also have early cycling without the result of breath stacking. And we'll see picture examples for all of this. So for auto triggering, the ventilator pressurizes without, I don't know what, it doesn't need to be highlighted red, pressurizes without inspiratory effort. Delayed cycling, the mechanical insufflation by the ventilator continues after the neural inspiration has ceased. Ineffective effort, the patient inspiratory effort is not followed by mechanical insufflation, meaning they take a breath, the machine doesn't respond, they can't trigger the ventilator. Delayed trigger is response, the ventilator, it's basically a delayed response by the ventilator, so they just don't give the trigger quick enough. And then reverse triggering, the patient inspiratory effort occurs after mechanical insufflation in a repetitive and consistent manner. Usually when you see reverse triggering, it's in a ratio like 1 to 1, 1 to 2, it's very rhythmic. For under assistance, the inspiratory effort is unsupported by the ventilator due to insufficient flow. Early cycling, the pressurization is shorter than the duration of the patient's effort,
and then double triggering 2 pressurized breaths. Okay. Now, a little note on diaphragm contraction. Normal breathing, we have concentric contraction of the diaphragm. That's a normal diaphragm contraction. The diaphragm shortens and moves downwards. As it contracts, we increase thoracic volume, facilitating inhalation. Eccentric contraction is when your diaphragm lengthens. So when we exhale, the diaphragm lengthens, and that's a normal activity as volume exits our lung. But in some patients, they may maintain some level of activity. This can be called expiratory braking, which resists the passive recoil of the lung and the chest wall. But it also could simply be continued effort, early cycling, the ventilator cycles off and they're still contracting. This is considered a form of eccentric contraction, but I clarify here because early cycling, and this was just brought up in a paper recently published by Ewan Gallagher and colleagues, when you have short cycling, it's a combination of the two, because if they trigger the ventilator, that's concentric contraction. But if it cycles off and they continue, then you have a little portion of it is eccentric, but because they're kind of both, they're calling it post-inspiratory loading. This might be one of the options in one of the quiz questions, so just remember post-inspiratory loading. And then, of course, it can result in a double trigger. Let's look, I already talked about auto-triggering and the causes, let's look at an example. Does anyone know how you would fix, let's say this. Before it shows you how to fix it, let's see if we can recognize. So this respiratory rate was around 28. I had already fixed it and then I turned it back, and that's why the rate's going up. But it was around 28 was the respiratory rate. How could I fix this? This is auto-cycling. You can see these pressure fluctuations, they're in the flow fluctuations. Patient looks fast asleep. I'm about to fix it, so you're going to know the answer. So flow is a very, very sensitive trigger. So I'm not saying don't use flow trigger. I'm saying it's if you have auto-cycling or you expect auto-cycling, changing it simply to a pressure trigger will resolve it, usually. Okay? So in that patient, just switching the pressure trigger, the rate all of a sudden dropped, but it was now the patient actually triggering the ventilator. Because you obviously can't get rid of the cause, and it's the patient's heart rate. I'm not going to stop their heart rate from beating. I don't want to, so I have to change the trigger. Now, I mentioned delayed cycling as a cause of ineffective efforts. This is a great paper by Mike Gentile and colleagues, and I don't have the reference up here. It's in respiratory care. But essentially describes that you have the neural inspiratory time is what the patient wants. And if your ventilator triggers, delivers the breath, and cycles off at the same time that the brain doesn't want it, amazing, you have perfect synchrony. If the brain stops and the ventilator is still going, again, this is pressure support. Pressure support, we have a cycle percent. So it's 25% of peak flow is when the ventilator decides to stop giving the breath. If it goes on past, this is considered excess time with flow. Volume is the integral of flow and time, so you get extra volume. So delayed cycling, not only does it increase your I time beyond what you want neurologically, that means you have basically an IV ratio problem. Less expiratory time means less lung emptying. You end up with dynamic hyperinflation and auto-PEEP, which starts to cause a trigger delay, increased trigger workload, and then non-triggered breaths. So that's if it's a cycling problem, but I will explain that delayed cycling can also be caused by giving too much pressure support. If your tidal volume is excessive, it takes longer to reach this peak down to here. So maybe if you lower your pressure support, you'll actually end up like this. But if you increase pressure support, it takes longer to get down here. And you may give too much volume. So you still end up with hyperinflation, but because you're giving too much volume, you change the patient's effort or drive to breathe. Their effort is weakened. So they, in between the breaths, because they're hyperinflated, they're trying to trigger and they can't. Okay. Now, Lorenzo had mentioned earlier, like adjusting PEEP to allow trigger. That is one mechanism for ineffective efforts. If you're setting a lot of PEEP at 0 all the time and then titrating up, you're going to see it based on PEEP in some patients. But if you're setting PEEP, essentially, and you don't have any evidence of like a lot of expiratory flow limitation, it's likely not going to fix your delayed cycling or your ineffective efforts. And I'll actually, just a quick note, I already mentioned this, it's commonly caused by over-assistance in time, but also occur in patients with strong inspiratory effort and just if you set too long with an eye time. I showed you the other screens where the eye time was too long. So this was a study that was done in terms of how to fix ineffective efforts. I would argue it's one of the easiest things to fix, but it's also the one you need to understand the most when you fix it. So here's evidence of ineffective effort, right? So they're triggering. You can see trigger, mistrigger, trigger, trigger, mistrigger. So if you think the problem is the trigger sensitivity, this is why I said it's not the correct response. They can clearly trigger the ventilator, but then all of a sudden they have a mistrigger. So they did a study looking at what if we adjusted 0 PEEP and providing PEEP, can we impact ineffective efforts or asynchrony index, which was just the ineffective efforts. What they found the best solution was simply decreasing pressure support. In patient, and again, but they said it was clear when they looked at the average tidal volume, it was around 10 mils per kilo before they reduced. And after they reduced it, they actually, can you guess what the tidal volume was after reducing pressure support, the average? It was about 6 point something, 7 mils. So Martin had mentioned earlier, that's actually normal tidal volume. So for years we've been calling it low tidal volume and it's been driving me crazy because if you look at the data, mammals on average breathe 6.3 mils per kilogram of predicted body weight. Whether you're a mouse or a whale, 6.3, that's the line, 6.3. So if you have 10 mils per kilo of tidal volume, like this patient here, you see this effort? This is how you looking for PMUS, evidence of effort. That's, the flow might be nice decay, but it goes down, you see this, and then it goes down. So close to triggering the ventilator, but not quite. They're too hyperinflated. But I want to point out, this is about 10 mils per kilo for that patient. And look at the respiratory rate. Guess what the nurses and respiratory therapists have been documenting all day? Respirate of 14. What do you think the real respiratory rate is? Closer to 25. You could guess 28 just by, because every breath is followed by a missed breath. So I knew before I fixed this that my respiratory rate was going to go up to close to 28 breaths per minute. I knew that. So one thing to always note, if you are a respiratory therapist or a physician that is altering this and you're not letting your nurse know what you're doing, make sure you explain before you do it. I've been into the room many times where I walk in, I walk out, I said, I fixed the patient. What do you mean? They're tachypnic now. This is not tachypnea, but sometimes you correct it, the respirate rate's 30 or higher. So understanding that the patient's still breathing the same here, it's just mask, you're masking it, you're hiding it because they can't trigger. But that doesn't mean they're not making an effort. It's there, the ventilator's not sensing it and not triggering the breath. So this is pressure support of 24, which is excessive, pressure support of 16. So 2 things you can look at for where you should definitely assess this. If your respiratory rate is less than 20 on a patient who's intubated recovering from critical illness, that's too low. Wean your patient. Even if you can't recognize this, I used to have students say, how do I know when I should wean my pressure support? I said, if your respirate rate's less than 20, just wean them. Because chances are, if your rate's 14 and you probably have ineffective efforts. Anyone here, if I intubated you and put you on a ventilator, I doubt you'd be breathing that comfortably. Unless you're heavily sedated. But that patient, I just weaned it and they were okay. Another thing to note is that when you over-support patients, this is essentially this is explaining what's called the apneic threshold or the eucapnic threshold. When we're breathing, we could hyperventilate ourselves and blow our CO2 down to 30, but we can't, it'd be very difficult for us to actually hyperventilate and have a central apnea because we're awake, we're alert. So this curvature here, we can blow our CO2 down, but we're not gonna go apneic. When you fall asleep, there's a shift in this metabolic, essentially, curve here, so that if you ventilate a patient below a certain amount, and you can see it's somewhere between 35 and 40, it can actually lead to a central sleep apnea. So for anyone who's worked night shift, how many of you have been called to a room for a patient who went apneic, and when you get there, they're wide awake because the alarm woke them up? So you walk in, they're looking at you, the nurse is like, they went apneic. And then, has it happened before? Many times. So this is why I joked earlier about SIMV being the nuisance mode. Many RTs will just put them on SIMV because, and like a rate of 10 or something. You should wean the patient. What's happening is the minute they fall asleep, you're blowing off too much CO2 and they have a central sleep apnea. Okay? So we're maybe going to talk about PAV and NAVA later. PAV and NAVA are proportional modes that cycle off when the patient doesn't want the breath anymore. The best evidence we have so far, there's another randomized trial that will be published hopefully this year that just finished, but the evidence we have so far is that it's superior for sleep quality. Why? Because you can't over support the patient. When it cycles off properly, it down regulates with them. When they go to sleep, it sort of follows their pattern. It doesn't over hyperventilate them, but pressure support can do that, and so you have these apnea thresholds. So if it happens, you can put a rate on if you want, but I would put a very low rate if you're going to put a rate. You don't have to use SIV. You could use pressure control if you want to avoid the alarms, or simply wean them. Just drop the pressure support. Okay, reverse triggering. I mentioned the machine gives a breath. There's evidence of PMUS, so this is pressure control. The machine gives a breath. There's no evidence of trigger, so A is pointing at the point where it doesn't look like they're triggering the breath. It gives the breath, and then again, in pressure control, I'm not expecting to see many changes in the pressure waveform. I'm expecting to see it in the flow. Remember the equation of motion? Look what the flow does. It starts to decelerate and goes back up. Then the ventilator cycles off, and there's still evidence. E is just pointing at the fact that there's evidence of expiratory. It's still continuing to breathe. So this is technically short cycling, but I would call this reverse triggering, okay? So patient makes an effort. Yes, there is some cycling, and it's short because there's still effort, but this phenomenon is reverse triggering. And if the effort, this is the electrical activity of the diaphragm, if the effort is strong enough, look what happens, breath stacking, okay? It can happen in volume control as well. The ventilator is pressurized, there's no trigger here, the ventilator goes up here, the peak is there, and then the effort is starting where the gray line is. This is esophageal pressure. This is where the effort starts, and so it's after insufflation, the machine is triggering the patient, they're making an effort, and you can still see this flow after this ventilator cycles off. You can see this ongoing flow, this upward deflection. Post-inspiratory loading. Post-inspiratory loading. Okay. We sometimes used to refer to that as eccentric contraction. I think the reviewers of that paper argued that it's not a full eccentric contraction, so they call it post-inspiratory loading. But reverse triggering is the main problem. How do you correct it? Well, it typically happens in over-sedated patients. So it happens as insufflation appears to act as a stimulus, the patient triggers. It happens usually in a ratio. I'll quickly point out that this was 1 to 2, 1 to 1, right? So it's usually very rhythmic and very patterned. The effort that continues into the expiratory phase may lead to breath stacking, but it's not a requirement for you to call it reverse triggering. This is important because some people, I read a paper years ago where they defined reverse triggering as a patient effort that caused a second breath. So that's not the case. It's common in patients that are sedated or transitioning out of sedation. So corrective measures, stop sedation if you can. Check if the patient's drive is sufficient. I can't tell you how many patients I saw reverse triggering. All I had to do was reduce the respiratory rate and the patient took over. Okay, so having said that, I have seen almost as many patients that when I reduce the rate, they just have no drive. So unless the ventilator is stimulating them, they don't do anything. You try pressure support and they just are apneic for 12 seconds. So check if the tidal volume also is sufficient. Some patients will respond to an increase in tidal volume and they'll stop the reverse triggering. But if it's not safe to do so, I wouldn't recommend increasing volume in someone with ARDS, for example. 8 is okay, but I wouldn't go up to 10 or something like that in someone who's way sick. So if breath stacking occurs, this was one of the recommendations that was sent out by Laurent Bouchard during COVID. He said if you have a patient that is breath stacking with reverse triggering, try an I time of 1 second in pressure assist control and reduce the respiratory rate by 25%, hoping that eventually the patient will start taking over. And again, this is when patients are transitioning from sedation. Many, many times when people that don't recognize asynchrony properly, what do you think they do when they see weird triggering and breath stacking on the ventilator? What do you think they do to the patient? Sedate them.
Increasing sensitivity.
What's that?
Increasing the sensitivity.
Yeah, they might do a number of things, but essentially if they see reverse triggering with breath stacking, the response is almost always like, oh, they just sedate the patient. The problem is we did a study on this, myself and Felipe Damiani, we published this paper looking at reverse triggering in the first few days of mechanical ventilation. And what we found is patients with a higher occurrence of reverse triggering are actually more likely to be switched to pressure support or extubated the next day. So if someone's doing reverse triggering as you're weaning sedation, is telling you that they're now interacting with the ventilator. That's We sometimes think this is a bad thing, but it's actually not. And they're telling you that I'm interacting. So we can try to manipulate the ventilator to make that interaction more successful, but sedating them is not the answer. Very rarely would you sedate a patient. And the only time I would consider that is if the patient has worsening ARDS, they have reverse triggering with breath stacking, so we know there's a risk to having 2 volumes delivered every time they take an effort. That would be the only time I would consider something like that. So whether it's lung injurious, we don't know. Diaphragm injurious, we don't know. Diaphragm protective, there's some nice data from my colleague Felipe Damiani looking at it actually matters on how strong the reverse triggering effort is. So in an animal model, if reverse triggering was associated with a strong effort, again, the effort that's more likely to cause breath stacking, there was diaphragm injury, not just lung injury. But with the weak effort, it was actually diaphragm protective. So again, just because you see reverse triggering, sedating or paralyzing is not the answer. It may tell you that A, it's okay, the diaphragm is okay, and it may tell you that they're ready for transitioning to pressure support. Okay. So I'm going to show you some pictures, and then I'm going to quiz you on these pictures afterwards. We're in volume control. This looks crazy to me. This is, again, if you're always wondering what's going on up here, look at the flow. Because above here is inspiration and that's exhalation. So clearly the patient is breathing in. Now, volume control is supposed to be square, right? This ventilator, if you pull hard enough, the default setting of this ventilator is to allow you, it almost gives you like a pressure support breath. That's why the flow is round. But this is PEEP, by the way. PEEP. This is inspiration. Look at how low the pressure is dropping. This is flow starvation. When you see this, what do you do immediately? Switch to a pressure targeted mode, please, thank you. Now, we did that. Having said that, we did that. The patient's breathing 10 mils per kilo, and that's on a pressure control of 6. We tried giving more because clearly the patient has a high drive. In fact, we just talked about P0.1, 9.6. After switching to pressure, 6.6, so that's a reduction, but it's still very high. When we increased pressure control, this was going over 12 mils per kilo of predicted body weight. This is a patient who had worsening ARDS. They're on a PEEP of 12 already and 60%. This is the lady who was not the PEEP responder. Remember the EIT talk? We sedated, paralyzed her, we did EIT, non-responder, we proned her. So this same day, we proned her. Okay. Now, what can you tell me? I'm just going to take this picture and move it over there.
This
What
is
can you?
ARDS case,
Yes, it was. Yes.
so the volume is very high now, we don't need to.
Yes, they're breathing spontaneously though. So on here, she's on volume control of 400 mils.
So
But she's pulling 500 from the ventilator, and look at the, like the ventilator's not doing anything. She's just pulling volume out of the ventilator. So
usually
we,
we need to keep low tidal volume for the ARDS, so,
well, we try.
yeah.
I'm saying sometimes you can't do it. So this patient clearly was uncomfortable. We switched to pressure. We still can't control her tidal volume. She's only getting pressure control of 6. And she has ARDS. Like this, that's why we sedated and paralyzed her and proned her. But I'm going to take this picture and put it over there. What other problem do you see? So clearly it's under assistance because huge drive, low support. I told you why we can't assist her more, but what can you tell me about the timing? The cycling. Is it short cycling? Is it late cycling? Is there an issue with cycling?
Short cycle because flow starvation means in inspiratory time is low, so it is not sufficient to get tidal volume.
So it's not short cycling,
It's late cycling.
it's late cycling. Why? What evidence do you see?
Because you have the shoot up of peak pressure.
There's a huge spike here,
Yeah,
right?
spike.
Yeah,
And then you
so
have-
pressure control of 6 above 12, it should be about 18. If you look, it's 25 is the peak here. You can see how high the spike is.
And
It's
then
just
you-
reaching 0. Yeah.
Auto peak, there is auto peak.
There is because she's like, the rate is set at 16, she's breathing 25. So I can't fix that. Again, this is why there is air trapping. I can't fix that. I mean, I can put it shorter, which that's exactly what we did here. There's a little bit more exhalation. Notice how the spike has come down, right? So late cycling, 0.8. I've reduced it. If we go too far, this is the same patient on 0.55 breath stacking. So now we have short cycling, and we have a second breath delivered. This example over here is also early cycling or short cycling. But this is on pressure support. Look for the trigger. Does the patient trigger? Yes. Is there work shifting? I mean, it's not very rounded. I wouldn't say this patient's working very hard at all. It cycles off here. You can see the breath stops. But look, you can see inspiratory effort ongoing. Now, I heard you say trigger. What is sometimes confusing is some people say that and go, oh, it's ineffective trigger. What you have to assume without esophageal pressure, I'm assuming that this and this are part of the same breath. It's an assumption you have to make because it's so close and because it seems to be cycling off very early. This is my inspiratory cycle percent. What would you do with that number? Would you increase it or decrease it?
We need to reduce.
Decrease it.
Decrease it, yes.
We need to reduce it.
Because this is my peak. It's cycling off at 60%. It's too short. You can see the effort still continues. I have to extend it, which means I decrease this down to allow pressurization to occur while the patient is still inspiring, okay? That makes sense so far? Now, a little note about early cycling and this increase here. I mentioned before that you also see it in reverse triggering, right? So which one of these slides, we'll call this A and this one B, which one is reverse triggering, A or B? Yes, why? Why do you think that? Look for evidence of trigger.
Because there's no trigger.
There's no trigger. There's no drop in pressure
And the
here.
patient is trying to make an effort in the middle of the breath.
Yes. So if you look here, it's very obvious the patient's triggering the ventilator. So as soon as you see that, this one is not, even if you just did process of elimination, this one cannot be reverse triggered because they are very clearly triggering the ventilator. What's happening here is the patient triggers. You see this increase in flow simply because the patient is still inspiring. Again, if I were to draw that red line of PMUS, it would go like this, right? So again, very close to almost breath stacking in these two breaths. This one, there's no evidence of patient trigger. Again, this is pressure control, so if I look at the flow goes down as it should and goes back up again. The ventilator cycles off and you have this little blunting of the expiratory flow. So both of these could be examples of early cycling, but this is where it can confuse you sometimes. You might call this, oh, that's early cycling, and you miss the fact that they didn't trigger the breath. Okay, so both of these are what we now call post-inspiratory loading, but two completely different mechanisms.
So the difference is here is patient is triggering, here is not the patient.
Correct. Reverse triggering. Yeah. Both of them, the clinical consequence is you have post-inspiratory loading. Whether or not this is harmful, we actually have some data. I'll be talking about it tomorrow, so we come to my lab. It's either tomorrow or whenever I'm talking about asynchrony. It might be on the 3rd. And I'll talk about it then. So, the post-inspiratory loading, how do we correct this? Monitor expiratory flow all the time and look for evidence of ongoing patient effort. If it's patient-triggered breaths, which on the left, we can easily fix that by just increasing either I time or decreasing inspiratory support, like we suggested with that patient there, okay? If it's reverse triggering, you can try increasing the I time, decrease sedation, you can try decreasing the respiratory rate and just see if they start breathing on their own. Because again, there might not be a problem with how long they're breathing, it's the fact that it's starting after the ventilator gives them the breath, that's why it's ongoing. But if you let them trigger the breath, it might not be early cycling anymore. You just have to let them trigger the breath. If they're ready for it, you'll find out.
What if we decrease the respiratory rate and their respiratory rate, their own respiratory rate
They
is
just-
higher?
Then they'll start triggering the ventilator. Yeah. So here's the problem with reverse triggering. Some people will say just try to switch them to pressure support and see what happens. And what'll happen is you may have a long period of apnea, and then a breath, and then a long period of apnea, and a breath, and what happens? Your ventilator alarms. So me, I don't like my alarms going off, so I'll walk to the bedside. If my rate's at 20 or 25, I'll turn it down to 10, and I'll wait. If the resulting respiratory rate is still 10, with reverse triggering still happening, because every time the stimulus happens, so if they follow your respiratory rate settings, like if they just continue to have the exact same problem on a rate of 10, I'm not confident they can gas exchange as well as I need them to. They can't maintain a minute ventilation yet. So, what also happen if I reduce it to 10. They may take over now, and now they're breathing at 14 or 16 breaths per minute, but they're triggering every breath. And now there's no longer reverse triggering. Because the stimulus is no there, they're now taking over. And so some patients it works, in some patients they will just be breathing 10 and you're like, that's not good enough.
What if they are breathing higher than 10?
If they're breathing higher than 10, that's fine. Try pressure support.
Okay. On pressure support.
Yeah, of course, yeah. I'm just saying, some people will say just switch to pressure support to test reverse triggering. If they have true reverse triggering, which is a problem, they might breathe 8 breaths per minute, which eventually you'll have a low minute volume alarm, etc. So I just reduce the rate to 10 usually and wait to see if they start triggering the breath.
And symptoms working with hypercapnia decreasing the rate.
What's that?
With hypercapnia.
Yeah, so if they have hyper,
Patient.
no, exactly.
Yes.
So I reduce it to 10, and if they're still breathing 10, or even 11 or 12, let's say they're triggering but it's 12, then the question is, okay, are they still sedated? Let's turn that down. If sedation is the issue, they may start to increase. That's why the other suggestion is that if you can turn off sedation, just reduce your rate by 25% while they're reverse triggering, and as the sedation weans, they'll likely start to take over sooner. If you keep the respiratory rate high, they may never start breathing on their own. You might always beat them to it because they just don't have the drive yet. But if you reduce the rate, it may cause that drive as CO2 starts to come up.
Yes.
So, and then they'll hopefully take over. Okay, we're about ready to vote. So just to review how we're going to analyze these waveforms, understand the control variable. I don't think I have any trick questions. If it doesn't say the mode on the screen, I will tell you what the mode is. And then you have to determine which waveform is going to show evidence. So triggering is very easy to look at. But when you look at the level of assistance, you're looking for evidence of PMUS based on the control mode, which you'll have to decide which one you think is changing. You're going to decide whether or not it looks like the patient is under-assisted or over-assisted. Pay attention to the cycling. Look for any expiratory activity. So if it's normal, it's a nice exponential decay when they exhale. If there's ongoing PMUS, you see a blunting of the peak flow and there's like that blip right away. Ineffective effort, it's usually in between the two breaths you see a mist. Okay? Breath stacking is very obvious to define. You can see it very clearly. But it could be caused by either the patient has 2 breaths triggered by 1 strong inspiratory effort, or reverse triggering, the PMUS continues after a machine breath, and it continues into exhalation and then results in a second breath. It could happen, but it may not. So these are the steps. And now, get your phones out. Let's see, 1, 2, 3, 4, 5, 6, 7, 8, 9. So I know how many people to wait. There's 14 in the room. I'm going to wait at least until 10, so get your votes in quick, because once there's 10, if you want to get done on time, I need at least 10 votes, okay? This QR code will also be on the next screen. If you feel like I'm going too fast, I'm going to switch slides, but you'll see it in the top corner. And the image is even on your phone, so if you want to tap on the image on your phone and zoom in, go for it, but it's also right here on the screen. So, would you classify this as over-assistance? Now this, I started off with a trick question, because I might be okay with either answer with this one, but I might ask you to explain why. This one has the P0.1 as well, if you remember. We only have 3 votes yet, eh? Nobody's that confident yet. 6, okay. I need at least 10. I didn't even count you back. 8. There's no wrong answer here. You can justify either one with this one. So, okay, one more vote. Come on, throw it in there. At least. Okay. Now, okay, so most chose over assistance and 40% chose under assistance. So, does anyone want to tell me why they chose over assistance? Because you're not wrong. There is a component that is over assistance. I just want to see if you can tell me what it is. And if you don't want to, it's okay. I think there's another question after this where you have to tell me what you think the problem is. And it should fall into that category, right? If you chose that one. No one wants to suggest why they chose over assistance? 69% of you chose it, but no one is confident enough to tell me why. Does anyone want to tell me why they chose under assistance?
Early cycling.
What's that?
Early cycling.
It is not early cycling.
It's late cycling.
Now, question, what made you think it was early cycling? Because this is a learning. Everyone here, there's no judgment here. I want you to leave here confident. So I want you, if you can explain to me why you chose early cycling, I can maybe explain why it's not. But I want to know where your thought process was first.
Yes, graphic of the flow.
Yeah.
No,
Was this what,
sorry.
you're looking up here, pressure?
Yes, pressure.
Yeah.
Big pressure above the pressure.
Yes, so this is delayed cycling or late cycling.
Okay.
So early cycling, you're going to see a blunting of the expiratory flow because effort continues on when the ventilator cycles off. Late cycling in this mode, for example, they're making very strong effort. This is why if you chose under assistance, it might be because I pointed out the fact that they're under supported. So this is kind of both. They're only getting 6 centimeters of water. I explained why we couldn't go up. It's already 10.5 mils per kilo in an ARDS patient with a very high drive. So yes, I would argue they're being under assisted, but to properly assist them, I would have to give them ridiculous amount of tidal volume because the drive is so high. So you're not wrong if you chose under assistance. Over assistance would be late cycling. So you're assisting in too long of a time. So, okay. So then this should be a very quick one because there's no option about under assisting so much. So what asynchrony do you see here? We just discussed it, so this should be a very quick vote. Notice how early cycling is not even an option, so you can't, that's why I didn't want to go next because it wasn't an option. And while you vote or walk through it, is the patient triggering the ventilator?
Yes.
Yes. So is it reverse triggering? No. Does it look like auto triggering? I would say it's very clear that that patient's making that effort. There's a huge drop in pressure. We have a large P0.1. Auto triggering, you'd have a very low, if not zero, P.1 because your heart rate's not going to generate a huge pressure change at P0.1. So definitely not auto trigger. Ineffective efforts, when I look through my expiratory phase, there's no evidence of clear PMUS. So process of elimination, we just discussed. The I time is slightly too long. Good. Always let some say auto trigger, but I hope I explained why it's not auto trigger. If the heart rate is triggering the ventilator or anything that's auto cycling, I mean, if it's a leak, the breaths will be right stacked together. Okay. If it's due to cardiac oscillations, you probably would see some fluctuations in flow, but you definitely would not see a huge drop in pressure. Okay. How would I fix this? Or how could I adjust the ventilator to better match with the patient, I should say? And there's a couple options here. Again, if I didn't tell you the story, or if it wasn't clear that the patient has, or if I didn't tell you they're developing ARDS and the tidal volume is already high, I would argue that probably one of the options, I'll give this away, would be to increase the inspiratory pressure. If this was any other patient, and I told you that we tried to do that, and the tidal volumes were they were over 12 mils per kilo. On pressure control of 10, they were over 12. It was crazy. Like the dynamic compliance of this patient's 75, so a change in 1 centimeter of water will raise tidal volume by 75 mils. So you give 4 centimeters of water, it's 4 times this, it's over 300 mils on top of the breath. So she would have got like 900 or 1,000. Oh, well, I have 5 votes here. You guys don't want to go home today. What can I do? So if you choose this, that's okay. If you can choose multiple options, go ahead. But I told you why I can't do that, so it's gonna be one of these, or I think you can choose multiple options on this one. I think I left it open to choose multiple. 2 more votes and then I'll switch it over. There we go. Okay, correct. Yes, I would do that if this was any other patient, and I did try to do that, so that's not a wrong answer. This one was the third. This is what we ended up doing with this patient and proned her. So all not wrong. The decreasing inspiratory pressure, I would definitely not turn the pressure control any lower than 6 centimeters of water. Clearly, that's not going to fix the problem, and nobody chose increased eye time, so that's good. Okay. This is the one. Wait, it's a different one. Okay. This one should go a little faster. The last one was, I wanted to start you off with the most difficult one. The rest of them, I would argue, are less difficult. This one should be very obvious. It's volume control mode. I should see 10 votes very quickly with this one. And if you use volume assist control in your institution, you need to know how to recognize this one and act immediately. This is probably the most traumatic for a patient, what's happening right here. If I didn't give it away with that. So let's hope we have 100% here. You ready? One more vote. Oh, some people still thought over assistance. No, I was definitely changing the vote now. It is definitely under assistance. My patient is, I've set 400 mils. They're pulling in 555 on a mode that's designed not to give you more volume. This is the peak level here, and they are inspiring so hard that the pressure is falling this far below peak before they even trigger the ventilator. They're forcing exhalate. This is a mess. But this is very clearly under assistance. My P0.1 is 9.6, which indicates a very high drive. Normal is 1.5 to 3.5, as was pointed out already. So this patient's clearly under assisted. Having said that, I pointed out that even trying to switch the mode and everything didn't work, but let's see, what's the problem here? Same patient. What would you call that? These are the 3 under assisted asynchronies that should go quickly. If anyone doesn't choose the right answer, I'm going to ask you to explain yourself because I want to learn so that I can explain better. I will not judge anyone, so if someone doesn't answer the right question, please provide me with feedback so I can teach better. 2 more votes. Do we want anybody? Some people are undecided. Oh, one more. Okay. Who chose early cycling? It's okay, I want to learn. And I think I know why. I think I might know why you're saying it. Okay. But the question really, like, what's the biggest problem here? So, is there blunting of the expiratory flow? There could be. Breath stacking, this is one breath. This can be hard to interpret because it's completely opposite, right? This is supposed to go up during inspiration. And instead it's going down because the effort is so strong. So this, breath stacking, this can be confusing, but just look at the flow. There's one breath, exhalation, another breath, exhalation, so it's not breath stacking. I understand early cycling if you saw this, but the biggest problem here is called flow starvation. This patient wants so much more volume. They're pulling the flow right out of the circuit, and the pressure is dropping below peak. They're inspiring so hard. Okay, this is flow starvation. Now, for those who don't understand, if you never use volume assist control, you'll likely never see this bad of a case. I've only seen this bad in this patient. This is the worst I'd ever seen, and I had to take screenshots of it because it was so bad. Okay. What can you do? Now, if you get this one wrong, I'm really going to be sad because I think I pointed it out 2 or 3 times. I said, make sure you do something when you see this. Anyone who gets this wrong just forgot that I said it. I'm going to go with that one. I will point out, all of these are possible options, but based on the strength of that effort, there's only one that I would do immediately. The other two, I wouldn't even waste my time.
Can we see this in PIVC?
Different. You will always see a positive inflection of pressure, but the delta P, like your peak minus peak, might be 3 centimeters of water. Some ventilators will go to 0. So your peak pressure would be 0 above, or it would be your peak, essentially. Your peak pressure might be like 13 or 12. But you won't see the negative pressure deflection like that. No. That's because the ventilator was trying to control flow. At one point it gives up, but it's not enough to even come close to supporting the patient. Okay. Here. Thank you very good. Thank you very much. Okay. 89%. Now again, technically, patient is demanding more volume. So whether you increase flow or increase volume, like those could be things you could try, but when it looks this severe, I wouldn't even bother. I would just immediately switch to pressure and then try to see if you can give a pressure level that supports the patient without giving excess tidal volume. Again, if this patient was healthy, young, didn't have ARDS, I wouldn't be as concerned about the tidal volume per se, depending on how high it was, because they could still cause their own injury. But in this patient, clearly, I don't want to give them more tidal volume. They got it when I switched over. They're already getting more than I set. But yeah, switch to a pressure mode, which is what we did. Okay. You know what's funny? I wrote descriptions for all of these and none of them are showing up. I don't know why. Are they showing up on your phone?
Yeah, yes.
They are? Oh, okay, good. I was like, why are they not on here? Okay, so I write brief descriptions on there. Like you walk into the room and you see. Okay. It makes more sense that it would show it here, but it doesn't. So would you call this over assistance or under assistance? This one's going to be a little tricky. Now, one of the things I mentioned earlier about ineffective efforts is that they can't trigger one breath, but what normally happens on the next breath? They can trigger again. Usually, like every other breath, they can trigger. I'll just point out, do you see any triggering? So remember, the first thing you always look for is probably triggering. So I'm just going to assume that some people thought ineffective efforts because they see this. I'm going to point out something. In this mode, I have set an inspiratory pause on purpose to detect plateau pressure. You see this plateau pressure here? Notice how there's no weird blip like you see here? That's normal. Look at these ones here. What does that tell you? There's a drop in pressure. In the inspiratory pressure, this is volume control, I see a drop in pressure, but it's not here now, right? It's not as obvious. There's a loss of plateau and this ongoing effort. Okay, so we'll go ahead here. So we thought 50-50. Okay. Oh, there we go. We got someone. I know you can change answers to or answered late. So anyways, we have under assistance or over assistance. Reverse triggering is classified as the over assistance. Okay, so this is, I gave away reverse triggering. You're going to know the next answer. So this under assistance, I see no real evidence of under assistance. There's not even a drop in the pressure normally during inspiration. There's no trigger. So under assistance assumes the patient is being assisted, but they're not even triggering the ventilator. So it's not a under assistance. It's under the classification of over assistance. Simply because I may be able to just reduce my respiratory rate, and maybe they'll be breathing 18 breaths per minute, but at 22, I'm causing them to entrain with the ventilator. They're getting the stimulus, and they're like, oh, okay, I'll breathe now. Let's get a few votes in here real quick. I just answered the question. What is this type of asynchrony? And now, I will point out, early cycling, that post-inspiratory loading is something we see similar in this type of asynchrony, If they didn't trigger it, so I'm trying to really get you to focus on the, and I think it even says like what's the most likely or the most specific form of asynchrony is this right here. That's why I was like, where are my descriptions? Because my descriptions hint whether I want you to focus in on one thing or not. I even gave away the name. I'm taking it really long to go there. I did cover my mouth. Very good. That's the one. So obviously you could select more options. So delayed cycling, interestingly enough, I'm curious why someone chose that. Just so I can explain why it might be, why it might not be. Does anyone want to admit that they chose delayed cycling? It's okay. Again, there's no judgment. I just want to know. So this pause is intentional. So just because you see a pause doesn't mean it's necessarily delayed cycling. I've set this pause to show plateau pressure on this ventilator. Delayed cycling would imply that they triggered and now they wanted to cycle off sooner. They didn't start their breath probably until here somewhere, and it cycled off before they were even done, so it's definitely not delayed cycling. If you had chosen early cycling, I would say, okay, I get it cycles off before they're done. Technically, it's early cycling, but reverse triggering is the main cause, and everyone that voted did choose that one. But if you had chosen this one as well, I wouldn't argue strongly against you that that was the right answer, and 100% of you did choose that. Okay. What are some things that I could do to correct this? And I think you could choose multiple options here. Definitely more than one option. Couple more votes. I lowered my threshold to 8 now, so at least we all are. It's the same code. Yeah. It'll just now show you the answers probably. Decreased sedation was the highest choice, and I agree with you. Again, now what if your patient they already had the decrease in sedation? Switch to press forward ventilation, very good. The patient is either going to take over breathing, or they might breathe but not sufficiently enough to maintain gas exchange. They might hypoventilate, their rate might be 8, but you can either do that. You can also do this. Again, I only mentioned that I do this instead of this just because I don't like alarms. So I'll just stand there, turn my rate down to 10, and usually if I'm in the room, I'm doing other things, so I'll put the rate to 10, and then maybe I'll check the humidifier bag, I'll check my filter, whatever, and then I see, what are they breathing? But either one would determine whether or not they have an intact respiratory tract.
This is depends upon the ABG. This ABG is good. We will go.
No, so this is just to test whether or not they can breathe sufficiently on their own. I don't care what their blood gas is. If their blood gas is okay with this, it's because I've done this to them, but maybe if I let them breathe on their own, maybe the minute ventilation will drop a little bit, but the gas exchange is okay.
So we can change it to CPAP also. It's not
Yeah,
CPAP.
it's whatever you want to do to see if the patient has a good enough respiratory drive. What you'll find with reverse triggering is some patients, when you try to see if they will take over, they don't want to breathe very much at all, and therefore you have to continue to take over. But, okay, I think I have one more question with this. No, I don't. So what I would not suggest, let's say you try pressure support and they're apneic. So you put them back on here. I would not suggest increasing sedation, decrease it if anything. I would not suggest neuromuscular blocking agents unless the patient is in active, like severe ARDS, I would say, with breath stacking occurring. Then you really want to control how much the patient may have injury. But otherwise, this may be protective for the diaphragm
and not at all lung injurious. We really don't know enough as to how to manage this. So right now, I would accept this if they could not take over a respiratory drive on their own. I would be okay with that. So let's walk it through as well. So some people are voting very quickly. Are they triggering the ventilator? Like, is there evidence of a trigger? Yes, they're definitely triggering the ventilator. So we know it's not reverse triggering. We'll go with that. But the level of assistance sometimes is difficult to determine, but knowing that in pressure targeted modes, if the patient is pulling in a lot of volume on their own, what should the inspiratory flow look like? It will be more rounded. If they're pulling it in, it's more rounded. They're not really pulling it in, so I wouldn't say it's under assisting maybe, because they seem to be getting enough assistance. There's no evidence that they're pulling in more than what I'm giving them during inspiration. And now we're gonna go and look at the expiratory phase. That's where the hint is, as to, again, not to what the type of asynchrony is, but in which category this falls under. Let's see how we did. Over assistance is the correct answer. This is considered over assistance because it's one of the main causes of this problem. Although the rate is 24, the pressure support above PEEP is 20, it's quite high support, so it would be difficult to say under assisting, but over assistance is the correct answer. Now, what type of, what do you, okay, so the question, I think the description is in the, can you read it, can someone read out the description?
What can you say about the patient respiratory rate?
The patient's respiratory rate, keyword is patient's. What can you say about the patient's respiratory rate? That's the trick question. Again, here's the respiratory rate on the ventilator. What can you say about the patient's respiratory rate? Now, to know the answer to this, you'd have to understand what asynchrony you're seeing right now. One more vote here, I'm gonna go ahead. Okay. Let's see what we have here. Most people said less than, oh, we got even Steven here. We got less than 30 and some say 30 to 40. It very well could be over 40 as well. We got some changing there. I couldn't figure out how to make it so you couldn't change your answer, but I see what's happening here. Okay, 24 breaths per minute is what the ventilator is measuring, because that's how many times it's triggering the ventilator in a minute. After every breath is a missed trigger. Ineffective effort, ineffective effort, ineffective effort. So at bare minimum, it's gonna be close to double. So if you said 30 to 40, I'm okay with that. The bottom line is it's higher than what you see, okay? Both of these I would have accepted. Right off the bat, if I multiply that by 2, it's over 40. So this is why I said it's important to understand this, because if I walk in the room and I turn my pressure support down, and now they start triggering every breath, and I walk out of the room and my respirate's over 40, no one's gonna believe me if I say I fixed a problem. They're gonna think I caused the problem. Right? And this is important, because this is the patient does not look tachypnic, but they are. They're actually breathing very fast, but we are completely masking the efforts in between each breath. They're masking it. So when you unmask it, the question now is, what do you do about it? I can't tell you that. That's a decision for the team. But this patient is clearly not weaning, like they're not tolerating ventilation as well as we think they are. Breathing 24 with good high volumes, like, oh, let's wean them. So you know what sometimes happens? Respiratory therapist who does not recognize this, or a nurse, whoever's adjusting the ventilator, if they don't recognize this, they go in there and they wean the pressure support. As soon as the patient starts triggering every breath, they think the patient is failing weaning, because the respiratory rate's now over 40, and technically they are, but they're not, it's no different, like you've just unmasked, they're still failing, even when you turn the pressure support up, there's still tachypnea. There's something causing them to breathe that fast, despite you giving them getting good tidal volume, et cetera. So it's important that when you unmask this, you don't immediately go back up. Or if I lean it down and they go over 40, you're gonna crank them full of sedation, right? Like, so there's things to consider that you have to acknowledge that even if I don't correct this, they're breathing fast. And this is considered eccentric contraction. The lung, or the diaphragm is lengthening as the lungs empty, and the patient is making a full contraction against that natural response of the diaphragm while they exhale. Okay, last few here. I think we already answered this, so I won't even bother with the votes. It is ineffective efforts, is what we saw. Okay, it is not early cycling. Now, if someone said delayed cycling, that would be a correct answer, because delayed cycling can lead to ineffective efforts. In other words, they're starting the breath right here. They might be done inspiring here. It's hard to tell because I don't have esophageal pressure. But delayed cycling leads to it. So clearly the patient wants to breathe here, here, here. So if I look at the effort here and here, my IE ratio is like 1-to-1 ratio. So I could reduce cycling, but I would much rather you decrease the pressure support, which is 20, which is very high.
But I cannot control cycling in the pressure support.
Yes, you can.
How?
Yeah. It's not on the screen here, but if you hit this button here, you have what's called inspiratory cycle.
But I said it's the backup rate, not.
There's no backup, no. There's a setting called, it was actually on one of the other screens.
10%.
It's called,
Yeah, with this one, I think it is historical.
yeah, inspiratory pressure, or there might be another picture that shows it. I had it earlier on, but the patient where it was at 60%, you can control how high this goes up. Many people feel the patient decides when they cycle off in pressure support. That's not the case. Okay, so how will we manage this? I think I gave it away. So there's two things we could possibly do. Let's see if we get the two right based on the conversation we just had. One is the first thing I would do. And then the second one is another option you could try. But because this patient has very good tidal volume and a high level of support, I would do one before I did the other. But there are technically two correct answers for correcting ineffective efforts. Two things work. Decreased pressure support is the first thing I would do, and actually increase the cycle percent is the second thing you could do. Yeah. Anyone who chose decreased, they're probably just thinking of it incorrectly. Ideally, you want to shorten the breath in this case, because the patient is being over-supported. This one looks similar to the last one. There are subtle differences. And again, if you had esophageal pressure on this ventilator or EDI or whatever, there would be no question as to what type of asynchrony. So although I'm trying to teach you to recognize it with pressure and flow, the gold standard is to have some form of monitoring like esophageal pressure or EDI. There are computer programs now. There's a software called BetterCare, which does very well at identifying these asynchronies. We help validate their algorithm for reverse triggering. And it's very, very good. It's just not, it is commercially available, but it's not very commonly, it's being used mostly for research at this point, but it will identify all of these things without esophageal pressure.
It's called BetterCare.
BetterCare is the software, yeah. It's out of Spain, actually. In Canada, Draeger actually distributes it. It has nothing to do with the ventilator, it's actually a computer for it. But it will connect to the back of any ventilator. So BetterCare worked with every manufacturer, and they can interpret the data being sent out the back, and it will interpret all of the types of asynchronies. As much as I'd love all of us to know how to recognize this, I acknowledge that if you had a computer doing it, it takes a lot of work out of it. Okay. Under assistance is the correct answer. What is the main problem here? And just so in case anyone's wondering what's going on here, this is just the ventilator goes like this across the screen, and it overlap, like it just removes, so this is just the you can ignore this part right here, it's just the cursor going like this as the patient's being ventilated. Recycling, very good. Breast stacking, there is no evidence of breast stacking. Again, for breast stacking, you would need 2 breaths without insufficient exhalation. That's 1 breath here, 1 breath here. Again, this is just the ventilator going along. But breast stacking would require 2 breaths immediately, so there's no breast stacking there. Early cycling is the correct answer. The patient is triggering. Ventilator cycles off. There's that evidence of ongoing inspiratory activity. Now, if this flow was high enough, it could result in breath stacking. So I don't know if my question was like, did my question say what it is and what could be a problem, or did it just say what's the most
How would
common?
you classify?
How would you classify it? Yeah, so early cycling is how you classify it. If the question was, what could be a potential consequence of this, breath stacking is the potential consequence. This is the last one. And then I just have one question sort of unrelated to classifying these. Well, listen. Now, there's a description on here that's very important. Can someone read it out loud?
We got called to the patient room after an ABG showed respiratory alkalosis. You observe the patient is asleep and no distress. What can you say about the assessments?
Does anyone automatically recognize what the problem might be based on the description? We're going to respirate a 28 person seems asleep and unaware and doesn't care about anything, seems nice and comfortable. You can see some clear, strange things on the waveform there. I'm actually going to point out something interesting with this picture once we discuss it. Over assistance is correct.
You
Should I
change
go back?
the one back.
How did that even happen? Okay, here we go. Whoops. Here we go. What is the most likely disintegration? One more. Okay. 40% had the incorrect response. The second option there is auto triggering. Yes. Now, what's funny is, who said reverse triggering? Because there actually is reverse triggering here. Anybody? Who chose reverse triggering? Because you're right, there is reverse triggering. It's not the main problem, but did anyone want to admit that they chose it?
I did.
Okay, good. Is it in all the breaths you think, or?
I think it's the second one.
It is, this is the second one, yeah. So again, if you have auto cycling, remember, reverse triggering, the ventilator gives the breath to the patient. First, the patient's not demanding it, the ventilator gives the pressure, and the patient responds with a reflex. When you have auto triggering, the ventilator is giving it no matter what the patient wants. So what's happening here, again, I wouldn't say this is classic reverse triggering at all, but there's a lot of pressure fluctuations, there's a lot of flow fluctuations. The key was in the description on your phone, it says that the patient was respiratory alkalosis. So they're clearly being ventilated. In order for a patient to do that to themselves, they'd have to be to Kipnick, but the patient was asleep, and patients are not going to be asleep and alkalotic unless they're being overventilated. So this is auto cycling, but what's happening here is that the breath was triggered likely by the auto cycling. And notice how the flow decelerates normally here, and here it's normal, but here it decelerates and then goes back up And this blip here is actually like ongoing inspiratory effort, so you have reverse triggering. The phenomenon is actually happening here and over here. So you're not wrong. It wasn't the intended response, but I had the option up there, and it's just had to point that out because there's been a few case reports of people describing reverse triggering during pressure support. The only way that can happen is that the ventilator is being triggered by something other than the patient. And here in this case, it was cardiac
Water
oscillation.
in the circuit.
What's that?
Water.
It can be, yeah, water can do it. Water's not likely going to be as constant. Like this one, it was very clear that it was likely cardiac oscillations.
But let's say the waves, doesn't we think that this is the patient?
This is the patient. It's their cardiac oscillations,
Cardiac oscillation.
their heart. Yeah.
Not the pacing.
No.
Oh, that's fine.
Yeah. No. Just
Like,
regular.
and ineffective.
So if you held an inspiratory pause and counted that, it would be their heart rate. So how would I fix this? I'm not going to take the patient's heart out. That would be horribly barbaric. Give a beta blocker. Yeah. We'd probably manipulate their heart in some way. What do we think the best response would be? The easiest one, without drugs. Just a slight manipulation of the ventilator. Change from pressure, or from flow to pressure trigger is the correct answer. So increasing inspiratory pressure, that might make it take longer because they get more volume. It may take longer before the auto cycling happens, but it wouldn't be the solution to the problem. But it could technically reduce respiratory rate simply by putting in more volume. Means it takes longer to get down to the part where the pressure was being triggered. Okay. The last few questions here are a little bit more combining. There's only 3 questions and then we are done. Choose the type of asynchrony and the potential concern for the diaphragm. So this is just thinking a little bit outside the box. I had mentioned a few things like eccentric contractions. I mentioned post-inspiratory loading. Of course, we have mentioned the types of asynchrony. There is one type of asynchrony occurring here that I want you to select, and whether or not you think it's post-inspiratory loading or eccentric contraction. Eccentric contraction is correct. Again, because the contraction is happening completely away from the inspiratory pressure, this is a full eccentric contraction. If it was happening, if this was early cycling, then it would be post-inspiratory loading, but because it's its own separate breath, it would consider it eccentric contraction. Now, nobody chose the, because I think you could make multiple choices, nobody chose the type of asynchrony. Does anyone want to yell out what type of asynchrony this is? We already had this picture. Is it reverse triggering? How do I tell? It's definitely not. There's a trigger on every breath, so forget that one. Ineffective efforts, yes. They're in between each breath, that's ineffective efforts. When it's really close to here, you have to consider, like, is it ineffective or is it short cycling? And in this case, it's ineffective. It's very consistently in between each breath.
So, question. So the difference between eccentric contraction and post-inspiratory loading is the dip behind after the.
Yes. Essentially, it's eccentric contraction that happens immediately after concentric contraction. So concentric is normal. You trigger and the ventilator gives support. That's a normal action of the diaphragm. Contracts, volume gets sent to the patient. When the volume gets sent to the patient and then it starts to exhale and you're still contracting, you have a combination of concentric and eccentric, so they're renaming it post-inspiratory loading. You're really far ahead of the curve with this one because nobody's talking about post-inspiratory loading in asynchrony talks yet. I might be the first. Not the first to talk about post-inspiratory loading, but I have not seen anybody teach asynchrony and mention this yet, so I thought I'd start now, since we have now 2 papers in publication that use the words post-inspiratory contraction or post-inspiratory loading.
Okay, choose the type of asynchrony and the potential concern for the diaphragm again. Again, so the concern for the diaphragm is either post-inspiratory or eccentric contraction. And then these are the types of asynchrony that may be represented over there. This one is going to be a very easy process of elimination. The patient is triggering, so clearly it's not reverse triggering. We just had one other one. I'm probably not going to do it twice in a row. So let's see if you can just, looking at the waveforms, you likely should be able to figure this out. And then we just discussed how we distinguish eccentric versus post-inspiratory loading. So. If someone chooses reverse triggering, I know that it's way too late in the day and is tired, because I just told you it's not reverse triggering. One more vote. Someone's going to do it now just to be funny. Okay, here we go. Post-inspiratory loading and short cycling, very good. Again, so for those who may have voted but they're still unsure, ventilator is triggered, gives the breath, cycles off. You see evidence immediately, a deflection in expiratory flow towards baseline. That means ongoing activity. So the contraction started here. That's a concentric contraction. It continues on. That's partially eccentric. Therefore, we have the post-inspiratory loading. Last one. I should have put two of the same, because now by process of elimination, you probably could just guess. But I want you to think it through anyways. For years, this screenshot, for example, every Draeger screenshot is from a hospital I haven't worked at in 8 years. So that's how long I've been collecting these images. The Servo U images are all at St. Mike's. The Servo I is at St. Joe's and Hamilton, so is the Draeger. It's been a long time. Okay, one more vote. Reverse triggering, very good. There's no evidence of patient trigger, right? There's not triggering the ventilator. Anyone who put ineffective efforts, again, if this blip was more in between, sometimes you can have 2 before the next breath, depending on how hyperinflated they are, but they're usually not this close to, again, if you had esophageal pressure, there'd be no question. But it's training the eyes to see and think it through. So there's no trigger, so right away it tells you that any patient activity after triggering is going to be reverse triggering. In this case, the flow starts to decelerate when the breath is delivered, as it should, and then it goes back up because the patient is now inspiring. Remember, I can see little things in pressure, but this is less likely to tell me what I want to know because it's pressure controlled. There's the flow, goes back up, and when it cycles off, there's this little bit of a blip, which is the post-inspiratory loading. Thank you. Now, we have, you guys can go.
Thank you very much. Thank you.
We all have significant jet lag, but I get extremely excited when I talk about asynchrony, so I have more adrenaline than everybody put together.
I don't get that from home.
Yeah, no, there's no excuse. There's no excuse. You have to stay. Okay, now because I said this is going to be very informal, we have 1 hour left. There were 3 potential discussions. This one here is on the, it's on this, but we had decided to change it at the last minute. If you notice, I had 2 coming up here. I didn't put my name on here, and then we decided at the last minute that I had to, like somebody had to, and I said, okay, I have slides, I can prepare for this. So, but I did not do this one. The other option was going to be airway opening pressure. So how to check for airway opening pressure, which actually would involve a demonstration with the ventilator. And also could do the recruitment to inflation ratio, which is a measurement you can do to assess recruitment potential at the bedside on the ventilator. The other option is talking about proportional modes like PAV and NAVA, sort of how they function, how they work, where they may be beneficial, etc. Or we have weaning versus liberation. We'll probably have time for one talk and then just an open discussion about anything. So, do I don't have slide voting for this. How many people, hands up, would like the proportional modes of ventilation? One? Okay. What about weaning versus liberation? Okay. And then airway opening pressure and recruitment to inflation ratio. Okay, so weaning and liberation wins. When he's done his presentation, we will discuss everything, anything else that you wish to discuss.
I shortened it, so probably we can do the.
We'll try. We have
I
one,
shortened the presentation in further.
perfect. We have 1 full hour anyways, so.
Huh? Sorry? 10 minutes, you wanna go 10 minutes for prayers?
Sure. Yeah. 5 minutes. If anyone needs to grab a drink of water, I'm gonna grab a glass of water. 5 minutes, so. At 4:07. We'll start promptly.